Hi, this is Ben Sirica. I'm a cardiologist at Brigham and Women's Hospital and a senior investigator at the TIMI study group. And what I'll talk today about is the management and diagnosis of stable ischemic heart disease. Here are my disclosures. So it's important to recognize that ischemic heart disease really does represent a spectrum of diseases that starts when we are at a relatively young age with cardiovascular risk factors like hypertension. It leads to endothelial dysfunction and the development of atherosclerosis. And then people will get symptomatic disease with angina, myocardial ischemia, infarctions. That can lead to muscle loss and fibrosis and eventual arrhythmias, with remodeling of the left ventricle and ventricular dilation, and eventually, in some cases, heart failure and end-stage heart disease. And typically, it is thought of as a disease that moves in one direction, but it's one that continually is a chronic disorder that includes many of the problems at the beginning, and is a systemic disease that progresses in cycles in and out of clinically symptomatic phases throughout a patient's life. Now, when one thinks of ischemia, we often think of angina as the classic symptom. And you can see that symptoms like angina actually occur at the end of the ischemic cascade. And so when somebody is having cardiac ischemia, the first thing that actually happens is there's an impairment of diastolic function where the left ventricle won't relax appropriately. This leads to increased filling pressures, then combined with systolic dysfunction can lead to symptoms such as shortness of breath. And then there are often manifestations on the EKG, but the classic angina really does come at the end of this cascade. And it's estimated that approximately 50% of patients with angina also experience asymptomatic or silent ischemia events. And many of the ischemic events that happen never actually become painful, so that the angina itself is a tip of the iceberg of the ischemia that is underlying in the myocardium. Now, this is a bit of the old school of how people thought about stable ischemic heart disease, that it really was limited to these blockages of the large coronary arteries, and the classic picture that people have in their mind is on the right of a aging male who, when he walks out of a restaurant, probably when he had some foie gras and other high fat meal, goes up the stairs in the cold, grabs his chest because he gets angina, the pain's so bad that he drops his cigarette, and that it really is on the left side of his chest, radiating it down to his arm. And there are certainly people who do get this classic type of angina, but it really is a much more complex disease. And it includes not only the small vessels, but the large vessels, but also the small vessels of the heart. And over the last decade, there's been an increasing recognition that the microvasculature of the coronary arterial tree not only becomes atherosclerotic, but also has a significant amount of microvascular dysfunction, endothelial dysfunction, and frank spasm that can lead to additional symptoms of ischemia and evidence of perfusion defects, even when the large artery may be open. And this is a condition that's often termed non-obstructive coronary artery disease, because we can't see this with typical angiography. And so the pathobiologic contributors to ischemic heart disease are not just the epicardial stenosis there on the left, the critical coronary stenosis, but it's also endothelial dysfunction, it's microvascular dysfunction, it's vasospasm, there's a interaction with platelets and the coagulation cascade, as well as inflammation. And for the clinician, it's important to remember that angina is the symptom for all cardiac ischemia, regardless of whether the underlying mechanism is large vessel coronary disease or whether it's microvascular disease. And therefore, the treatments must be focused on both ends of the spectrum. So how do we evaluate a patient with suspected angina? And when I use chest pain here, I'm using it in the broadest sense of ischemic discomfort. History is key, and really the initial evaluation that tries to tease out when somebody gets their symptoms, how often they occur, what level of stress they come on, do the symptoms come on at rest or with exertion or with emotional stress, are there associated symptoms? All of these are critical for understanding the pretest probability of whether you think these symptoms really are ischemic heart disease. The physical exam is important to identify other risk factors that might be contributing to this, like the presence of peripheral arterial disease or any evidence of volume overload. EKG is indicated, and then really trying to address all of the known risk factors for ischemic heart disease, so hypertension, diabetes, cholesterol, family history, smoking. These are the ones that you have to know. And based on all of this, one comes up with the probability of significant ischemic heart disease. And the most common way of binning the probability is into low, intermediate, and high categories, and then estimating what is the risk of a major vascular event if heart disease is present. And these two different points, first one needs to estimate the probability of ischemic heart disease and then risk stratify them. Often get confused, but they must be taken step by step. And when we're thinking about the pretest probability, we often do talk about, is the pain of angina typical or atypical? And typical angina is defined as substernal chest discomfort with characteristic quality and duration. The chest discomfort is provoked by exertion or emotional stress, and it is relieved by rest or sublitroglycerin. Atypical angina is defined as meeting just two of those three criteria, and non-cardiac chest pain would meet just one of those criteria. And you can see, based just on the fact whether somebody has typical, atypical, or non-anginal chest pain based on these criteria, the pretest likelihood of coronary artery disease is going to vary dramatically. And it's also going to be very dramatically based on age, where obviously as one gets older, your pretest probability of coronary disease is much higher, and also between men and women. Women certainly do have coronary artery disease, but it tends to be only more common as they get older. Now, why is this important in terms of estimating somebody's pretest probability of coronary artery disease? It's important because none of our non-invasive tests, and I'd say even our invasive tests, are perfect. And so we have to go into a test knowing what the result will change our post-test probability. And this is an example of stress testing. And the idea is that a stress test, the results of a stress test will change somebody's pre and post-test probability based on where they are. So for example, if somebody has typical angina, and say this is a 45-year-old gentleman on the right here, just based on his history and his age, his pretest probability of coronary disease is about 90%. If somebody has atypical angina, it's in the middle, around 50%. If they have non-cardiac chest pain, it's probably 5%. A test that's normal in green versus abnormal can help move your post-test probability here on the left. The greatest value of a test like a stress test is the area in the middle, these indeterminate people, where the result of the test, a positive test with 1 millimeter ST depressions, will change your post-test probability fairly dramatically. In somebody who has a high pretest probability, you're still going to have a high pretest probability, even if it's post-test probability, even if it's normal. If somebody has a low pretest probability, even a positive test is going to still have a low post-test probability and thus look likely to be a false positive. And so you can get faked out with the false positives with the low risk. You can get faked out by the false negatives at the high risk. And so the value of these non-invasive tests is really for the intermediate population. Now, how do the different tests perform? This is some standard data that comes out. It shows the difference between exercise tests with just an ECG through different types of pharmacologic or testing with and without imaging or with exercise. And you can see the sensitivities and the specificities do vary. You tend to get a bit more sensitivity and specificity with imaging than compared to a stress test alone. The guidelines in terms of how to diagnose somebody with ischemic symptoms and see if it's coronary artery disease are the following, is that if a patient is able to exercise and there's no contraindication to stress testing like critical aortic stenosis, if they don't have any previous history of revascularization and their ECG is interpretable at rest, if they're low or intermediate risk, low or intermediate probability of ischemic heart disease, then a plain old standard treadmill test with ECG is recommended. If they're felt to be high risk, intermediate to high risk, or if they've had previous revascularization, then they should get myocardial perfusion imaging with exercise, ideally, or echocardiographic with exercise. And one important thing is if somebody can exercise, you should always try to exercise them, because their exercise capacity, their heart rate and their blood pressure response and their actual total time on the treadmill is an important insight into their overall cardiovascular health. Now, if somebody has known ischemic coronary artery disease, then one moves into risk stratification. And you can see that there are a couple ways in this pathway that one can work through to identify patients who would benefit from further testing after their ischemic non-invasive testing. So if somebody has known ischemic disease, is able to exercise, they would get a stress test. Based on these stress test results, and you can see they vary depending on whether there is a resting ECG is interpretable. If a patient has a high risk coronary lesions, then somebody should consider coronary revascularization for the implicit and explicit reason that revascularization at that time could improve survival. If they don't have high-risk features, then observation on guideline-directed medical care is recommended. If it's successful, then just need regular monitoring. If they're still symptomatic or have other high-risk features, then coronary angiography and revascularization is indicated. If somebody does not have and that is irrespective if they do or do not have coronary artery disease. If somebody has a left bundle branch on ECG, they can't exercise, they should get a pharmacologic stress. And if there is indeterminate findings, then in this case, a coronary CTA finding can help identify any high-risk lesions. A big question is, what's the best method for diagnosis of coronary artery disease? And there are two broad camps in this. There are the anatomists who feel that getting pictures initially had been through coronary angiography, now it's more frequently from CT angiography are best, versus the ischemist or the functionalist who feel that studies from functional studies like stress tests offer the most important information. And so if we look at some of the numbers we saw beforehand, the detection of coronary artery disease in low to intermediate risk chest pain patients, here are the numbers on the treadmill testing, the imaging that we saw beforehand. And if we now add in cardiac CTA, we can see that the sensitivities and the specificities are actually quite high relative to the imaging of that's done non-invasively with nuclear images or echo. Altogether, if you combine all these things, you can see that you can overall get a negative predictive value of 99% if you're using multimodality. But these are, we are now getting to a point where we can have very good assessment in terms of sensitivity, specificity, positive predictive value, and negative predictive value. And the negative predictive value is important because that really does reassure somebody that they don't have critical coronary artery disease. Now, this test of what's better, a CTA or a exercise test was evaluated in the PROMISE study, which randomized 10,000 patients to either an anatomic strategy where they underwent CTA with a 64 plus size machine, or a functional strategy where they either had exercise EKG or exercise imaging, or went straight to a pharmacologic stress imaging. All of the tests were read locally. The results were immediately available to the physician, and then the subsequent management of the tests and testing was determined by the site care per standard guidelines. And these patients were followed for 12 months. And the question was, which is better first at preventing the primary endpoint, which was death, MI, unstable angina, or major complication. And you can see over the 12-month initial period and then the 42-month follow-up, there was no difference between the two strategies. It didn't matter if you had evaluated the person with a CTA or with a functional test. Their risk of death, MI, unstable angina, or major complication were exactly the same. So let's dig into this a little bit to try and understand how the different strategies differed. And you can see that there were differences, and this is within 90 days. Those patients who were assigned to the CTA had more radiation slightly, 12 versus 10. And almost everybody in the CTA group obviously got radiation, where only 2/3 of the patients in the functional study did receive some type of radiation. Most patients did receive the therapy that they meant to have. Nuclear stress testing was used in 12% in the CTA patients, and 14% of the functional patients. And similar, there was about 12% of stress echoes in the CTA, so those would have been crossovers. And then a little bit more exercise ECGs in the CTAs versus the functional. Again, in part because probably people after their CTA wanted to have other evidence, so after the CTA, they looked for some clinical or functional correlate to the findings. In terms of rates of catheterization, patients who were treated with CTA were more likely to undergo invasive catheterization, 12.2 versus 8.1. They were more likely to have catheterization with obstructive coronary artery disease. In other words, the caths that were done were more likely to have obstructive coronary artery disease. And they're about twice as more likely to get revascularization, whether it was PCI or CABG. Overall, patients who underwent CTA were a little bit less likely, and this is the first line here, to have a catheterization without coronary artery disease. So about less than 5% in both groups had clean coronary arteries if they were sent, but fewer patients in the CTA were sent and found to have no coronary artery disease, which is not surprising since there was a CTA that was done beforehand. So overall, in conclusion, these two tests do provide complementary data, but they tend to perform fairly similar. And part of the reason to choose one test over the other is what's your question and what's your pretest probability. A CTA will be very good at excluding coronary artery disease and epicardial coronary artery disease, while a functional study will give you more information about left ventricular function, about exercise capacity, and if there is physiologic defects with exercise. Now, after you've diagnosed somebody with coronary artery disease, the next part is to risk stratify them. And we use three different major buckets for this. There's the clinical parameters, there are the non-invasive and testing, and then there's the coronary imaging, whether it's calcium scoring, CT angiography, or standard coronary angiography. And these three parameters then help you identify what's this patient's risk for future cardiovascular events, and then it helps titrate the level of intensity of therapy either medical or revascularization that's needed. Now, the comprehensive management of somebody with stable ischemic heart disease goes through several steps. The first is to identify associated diseases that precipitate or worsen angina. That's like anemia, hyperthyroidism, atrial fibrillation with rapid ventricular rate. Secondly, to reduce the cardiac risk factors. Third, apply non-pharmacologic methods like lifestyle interventions and smoking cessations. Then in pharmacologic management, first apply the disease-modifying therapies for secondary prevention, and then attack symptom relief. And then the last important step is revascularization when appropriate. And there really are two principal goals for the management of patients with stable ischemic heart disease. And they include prevention of MI and death. This is disease-modifying type of therapies, and that improves your quantity of life. And then there is the therapies that reduce ischemia and relieve anginal symptoms, and this is improving your quality of life. Now, what are our goals of therapy in stable ischemic heart disease? They're multifold. They are antiplatelet therapy, including aspirin and a ADP antagonist, and in some cases, whether it is dual antiplatelet therapy for several months, 1 year, or prolonged, based on their coronary anatomy and their history. There's the use of ACE inhibitors or ARB, especially in diabetes, heart failure, reduced ejection fraction, or hypertension. There's the use of high-intensity statins, those drugs that lower LDL by greater than 50%. So that means atorvastatin 40 to 80, rosuvastatin 20 to 40, or ezetimibe 10 milligrams, and then the PCSK9 inhibitors if patients still have residually high cardiovascular risk to get the LDLs as low as possible. Secondary prevention measures also include smoking cessation, blood pressure control, appropriate use of diabetes agents to not only reduce A1C, but choose diabetes therapies that have proven cardiovascular benefits, reduce BMI, physical exercise, and the influenza vaccine. And these are the therapies that make people live longer. And the greatest evidence for life-prolonging or MI-reducing therapy is with optimal medical therapy. As we'll talk about, revascularization is very good for reducing angina and minimizing the need for recurrent coronary interventions, but except in a small high-risk subpopulations, immediate revascularization for stable symptoms does not prolong life or reduce the risk of future myocardial infarctions. And unfortunately, we still fall quite short in terms of achieving optimal medical therapy even after PCI. And you can see that getting people to target LDLs, blood pressure, smoking cessation, still is less than 2/3 of the patient have achieved these goals. So what are the factors affecting the development of angina in patients, and how do we address now symptoms? Remember, it's a simple oxygen demand and oxygen supply balance that leads to ischemia. And there are many things on both sides that will affect both the oxygen supply and the oxygen demand. And it's by modulating these basic physiologic parameters that we can decrease oxygen demand or increase oxygen supply and help reduce ischemia. Now, the goals of therapy in stable ischemic heart disease to reduce symptoms are first using the medications that reduce heart rate, blood pressure, contractility, and preload. And these include beta blockers, calcium blockers, nitrates, and ivabradine, and the medications that affect myocardial calcium homeostasis, in particular ranolazine. Now, the traditional anti-anginal agents like beta blockers, calcium blockers, nitrates, and ivabradine tend to have their effect on decreasing heart rate, blood pressure, myocardial contractility, and trying to increase coronary flow. The different calcium channel blockers, the dihydropyridine versus the non-dihydropyridine, will have differing effects, in particular on the heart rate, and so they can be used with and without other beta blockers. Ranolazine has relatively little clinical effect on any of these, with just a small reductions in blood pressure, but no meaningful effect on heart rate. Now, if you look at the studies that have evaluated the different anti-anginal agents, beta blockers versus calcium channel blockers, nitrates versus calcium channel blockers, nitrates versus beta blockers, the take-home message is that for the treatment of angina, no anti-anginal therapy has been ever shown to be superior to another one, and they tend to all have a similar type of reduction in terms of improvement of exercise tolerance and time to ST depression, and so they can be felt of as fairly similar in terms of their anti-anginal effects. Now, that being said, there are some agents that we tend to use more than others, and beta blockers are one of those, where beta blockers have good evidence for early use after a myocardial infarction, but in patients with coronary artery disease but without MI, the data is less clear. And there was a study from the REACH registry for in patients with CAD but out prior MI. There was observational data that beta blockers were were not associated with better outcomes compared to patients not on beta blockers. And in the Charisma trial, a similar story where beta blockers were not associated with improved outcomes in those patients who'd never had a history of MI. And it's based on that data that the guidelines for the treatment of anginal symptoms starts still with beta blockers because of their evidence of a mortality benefits in recent MI, but also includes calcium blockers or nitrates as class 1 indications, and ranolazine as a second-line agent if patients either have contraindications or persistent symptoms. And here's a summary of the recommendations so that the three agents, beta blockers, calcium blockers, and nitroglycerin, have class 1 indications, ranolazine a class 2A indication. The Europeans, for angina relief, recommend short-acting nitrates and then beta blockers or calcium channel blockers that reduce heart rate as their first-line agent. A calcium channel dihydropyridine like amlodipine is indicated for a low heart rate or intolerance to other meds. And then the combination may be used as well, with second-line agents being ranolazine, ivabradine, and nicorandil. Ivabradine and ranolazine are available in the United States. Nicorandil and trimetazidine are not. Now, there are some reasons to pick some of the beta blockers versus the others, and this is some data from a randomized trial that looked at carvedilol versus metoprolol, and metoprolol had a worse metabolic profile than carvedilol following hemoglobin A1C over just about a 5-month period where there was a significant difference between the two. So if somebody has diabetes, it may be worthwhile to choose carvedilol versus metoprolol. Now, all the anti-anginal therapies have conditions that may limit their use. Beta blockers sometimes in a small proportion of patients will cause a reactive airway disease. They will obviously exacerbate any existing bradycardia or AV block, and in patients with Raynaud's syndrome, they can worsen their symptoms. Nitrates need to be avoided in aortic stenosis in patients with dynamic obstructive outflow lesions, and they should not be used together with any PDE5 inhibitor. Calcium blockers, especially the non-dihydropyridines, will also exacerbate conduction disease. They should not be used in heart failure or LV dysfunction. And ranolazine should not be used with other QT prolonging drugs or with strong CYP3A4 inhibitors like ketoconazole. The side effects are listed here, with nitrates being headache the most common, beta blockers, fatigue and headache and cold extremities, calcium antagonists with edema, headaches, and sometimes constipation, ranolazine being nausea, asthenias, and constipation, and ivabradine with nausea, constipation, and anesthesias. And so often starting low is important, and sometimes lower doses of 2 drugs are better than maximizing 1 drug. Now, what about what's better, medical therapy or stent implantation in patients with stable ischemic heart disease? This is a meta-analysis that looks at the outcomes of death, unplanned revascularization, myocardial infarction, or persistent angina during follow-up. And you could see that for the cardiovascular events of death and MI, there is no difference between stents and medical therapy. Unplanned revascularization was less frequently when stenting was used first, and symptoms were improved with fewer angina in patients who had received stenting first. Now, this observation that's been seen in many different studies that overall stenting does not improve mortality or MI still is often lost on the public. And here's a study that looked at patients' belief, and you can see that neither referring or interventional cardiologist really thought that PCI was going to improve mortality or prevent MI, but the patients certainly did. Everybody thought it was going to reduce angina. That's appropriate, but the patients had unreal expectations. And why do we say that the revascularization doesn't always help? There are studies like the COURAGE study that looked at this specifically and did not see any benefit in terms of mortality or MI in patients treated with PCI versus optimal medical therapy. There's the Barry 2D study that was a 5-year study looking at patients with diabetes where revascularization, whether it was PCI or CABG, had no mortality benefit compared to guideline-directed medical therapy as an initial strategy. And here's the COURAGE results where you can see over a 5 to 7 year follow-up, no difference between the two therapies. Now, unfortunately, there hasn't been a huge change, I would say, in utilization. There has been a little bit less utilization of catheterizations and PCI for stable angina since the COURAGE results were published, but the indications for other reasons has continued to stay similar. Now, there's been subsequent studies from these that have tried to combine a little of the anatomy plus the functional by looking at FFR-guided PCI versus medical therapy in coronary artery disease. So this is a technique, FFR, to try to identify lesions that are physiologically tight at catheterization. So a pressure wire is placed across the lesion, and in this study, 1,200 patients with stable coronary artery disease who were scheduled for PCI were included in this study. And there was a randomized part where if there was any of these stenosis which had an FFR of less than 0.8, meaning it was hemodynamically studied, they were randomized to either PCI plus medical therapy or medical therapy alone. And then there was a registry part of this if they had coronary angiography that looked severe, but when an FFR was done, it was not felt to be physiologically severe. They were just randomized. They were just put into a registry and followed with medical therapy. And they were about 27% of the population. Now, the final results showed that the patients who had PCI plus medical therapy in the red had the lowest rates of death, MI, or urgent revascularization. Medical therapy alone had the highest. Now, it turns out that there was little difference in terms of death, little difference in terms of myocardial infarction, and the real difference was in unplanned urgent revascularization. That's what drove the difference between PCI and medical therapy in this study. And not hard endpoints like cardiovascular death or MI. Another recent study called the Orbitus study tried again to look at patients with stable ischemic heart disease. It was a small group. All the patients had medical optimization for 6 weeks. They had an assessment of functional capacity and quality of life. They underwent a blinded procedure, meaning that the patient didn't know what they were getting. They looked at FFR and other metrics of physiology. They were followed for 6 weeks and then had a follow-up assessment. So this was a small study of about 200 patients that tried to look at what was the effect of this type of therapy. And you can see that the difference between PCI and placebo was fairly small in terms of increment in time to stress and improvements in their angina quality of life questionnaires. All of these were non-statistically significant, except for an imaging study that showed that peak stress wall motion index was a little bit better with PCI versus medical therapy, meaning that the stress test findings showed a little bit better activity, but all of the other parameters were not significant. Now, in this study, they then have recently published the fractional flow reserve and their instantaneous free wave ratio, which are cath lab-based tools to assess the severity of a lesion, and saw how they responded, how patients responded based on these physiologically important data. And what they found overall in this analysis, that more patients treated with PCI were angina-free at follow-up. And that's right here. You can see the dark red versus the gray. And so consistent with other studies, PCI achieved angina freedom much earlier than PCI. The severity of the lesion effect on PCI on wall motion score was significant, so that the more severe lesions, if they were fixed by PCI, they had better effect on imaging results, but that didn't seem to have any effect on symptoms. So in many of these cases, they were treating lesions and they made pictures look better, but they didn't make symptoms better. So this study has, I'd say, only further contributed to some of the controversy that consists on what's the role of PCI and in stable ischemic heart disease. And unfortunately, we have a lot of debating ideas. There was the Orbita study. The editorial to the Orbita study said the last nail in the coffin for PCI and stable angina. That was followed by a counter-argument, the Orbita trial, why it's not the last nail for coronary angioplasty and stable angina patients. And we remain in a situation where PCI in general will not improve morbidity and mortality in terms of stable ischemic heart disease, but does improve symptoms. And so it is an important adjunct in the therapy to try to reduce symptoms in patients with stable ischemic heart disease who do not have symptom relief with medical therapy alone. So what about the question of PCI and CABG? PCI is obviously less invasive, fewer complications, shorter length of stay and faster recovery. CABG, though, has more durable results, more complete revascularization, and in general will require fewer revascularizations in the future, albeit with a upfront risk of a slightly higher risk. So what are the recommendations where we are now? That for when there is a question about multi-vessel PCI or CABG, a heart team approach is appropriate, that the cardiac surgeon, the cardiologist, the interventional cardiologist, as well as the patient should be all involved in the decision to identify the optimal setting. The second thing that's helpful to try to put a little objective data around it is to calculate an STS and Syntex score to try to understand how complex somebody's coronary artery disease. And this is because there was a study called the Syntex trial that looked at patients with severe three-vessel disease or left main disease who were randomized to either PCI or drug-eluting stent, PCI with drug-eluting stent or CABG, and followed at 12 months. And you can see that overall, patients treated with CABG had a lower rate of major adverse cardiovascular events compared to PCI and drug-eluting stents. And in particular, this was driven by much higher rates of repeat revascularization with the PCI versus CABG. There was no difference in death, MI, or thrombotic events. And there was an observation that patients with diabetes seemed to be more likely to benefit from CABG compared to PCI. But also, if you took a Syntex score, which is a complexity of coronary disease, you can see that patients with the highest Syntex score on the far right and intermediate Syntex scores had greater benefit in terms of reduction in cardiovascular events with CABG in blue compared to PCI in red, whereas in lower risk anatomical patients, there was no difference between the PCI and CABG. So it makes sense that more complex patients will benefit from more complete revascularization of CABG. This was also seen in the Berry 2D study, where patients with diabetes who were felt to be at high risk tended to do better with CABG compared to PCI, to medical therapy, whereas the PCI versus medical therapy in high risk had no difference. So the inference here is that if one has diabetes and has a high risk features, they're more likely to benefit from CABG compared to PCI, and CABG is definitely looks to be better than medical therapy in that situation. Now, the FREEDOM trial also evaluated patients with type 2 diabetes after randomization and looked for 5 years after randomization and found a similar story where CABG in this patient population was associated with or did lead to fewer death, non-fatal MIs or stroke, but also reductions in death alone or MI alone with an increased risk of stroke, which is commonly seen with CABG versus PCI. So the recommendations for revascularization, level 1 recommendations are CABG is indicated for patients with significant left main disease, for those patients with significant 3 vessel disease, including with or without proximal LAD disease or proximal LAD with other arteries. CABG or PCI are recommended to improve survival in patients with sudden cardiac death where there is VT caused by significant blockages. And the last bullet point here is that CABG is generally recommended in preference to PCI to improve survival in patients with diabetes and multivessel disease, especially if a lemograph can be used. The Europeans have a similar type of recommendation where they break things down in terms of to improve prognosis or to improve symptoms, and the same type of criteria for revascularization are here as well. And in particular, if somebody doesn't have symptoms and they have disease in vessels other than the left main or proximal LAD, then there's very little indication for revascularization in that situation. So in summary, in terms of revascularization, the important message is not everybody with angina needs to get revascularized, and we need to slow down the train a little bit. There is some favorable short-term, these patients have favorable short-term prognosis. Medical therapy is what's going to make them live longer and have fewer heart attacks, so we should give that a chance to work. And it's also a chance to get to know your patient, to understand what their symptoms are and what they would like. PCI does not change the natural history of stable ischemic heart disease, but it does improve quality of life, especially those with high symptom burden. And FFR-guided approach is likely to provide a better guide than straight angiography percent stenosis. CABG improves outcomes and death and MI in patients with diabetes and high-risk anatomy, and a heart team approach really is important so that in patients with complex anatomy, everybody's able to assess what's the optimal therapy. And it really does need to have individualized approach based on a patient's comorbidities, their anatomy, as well as their preferences. So in conclusion, for stable ischemic heart disease, optimize risk factors to prolong life. Optimal medical therapy is indicated for everybody with stable ischemic heart disease, and revascularization in specific symptoms. The goal is to eliminate symptoms regardless of the etiology of the ischemia. That means trying to individualize antianginal therapy. Choose medications that can treat more than one problem, hypertension or atrial fibrillation, for example, if possible. Often lower doses of several agents may reduce side effect profile, and sometimes it is a trial and error process, and it may take weeks to find the best therapy. And then patients do need constant reassessment of symptoms and side effects because stable ischemic heart disease is actually a dynamic disease and may be different from one year to the next. So never forget to ask a patient who has stable ischemic heart disease, really how are they doing in terms of their functional capacity, their exercise tolerance, and any symptoms. Here are some important references. Then the first question, 56-year-old man presents with symptoms suggestive of exertional angina. They begin after moderate exertion and resolve with rest. There's been no rest pain. Has a history of hypertension and dyslipidemia for which he's taking losartan and simvastatin. Exam doesn't have any signs of volume overload or heart failure. His EKG has mild PR prolongation but normal QRS and no ST segment or T-wave abnormalities or Q-wave. What is the next most appropriate test? A, echocardiography. B, exercise stress test. C, exercise stress test with radionuclide imaging. D, pharmacologic stress test. Or E, this patient doesn't need testing at this time. The correct answer is B. This patient has classic symptoms of chronic angina, but otherwise appears to be at relatively low risk given his comorbidities. The first step, according to the AHA-ACC guidelines, as a person with suspected angina is to perform a stress test. Exercise is preferred because of the prognostic data regarding exercise capacity, time to symptoms, heart rate, and blood pressure response. In patients with an interpretable ECG, radionuclide imaging is not indicated. If this patient were to have documented ischemia on stress testing, then an assessment of left ventricular function is indicated to try to further risk stratify them. Next question, which of the following tests is least likely to provide any incremental prognostic information in patients with established stable ischemic heart disease? A, echocardiography. B, cardiac magnetic resonance imaging. C, NT-proBNP or BNP. Or D, computed tomography calcium score. The correct answer, which is D, is that all of the other ones actually are important. Left ventricular function is critical in the evaluation of patients with stable ischemic heart disease. Therefore, echo does provide important prognosis. Cardiac MRI is reasonable. In addition to providing data regarding left ventricular function, it may also look at myocardial viability and evidence of old infarct. NT-proBNP and BNP has been shown to identify patients at greatest risk of death or heart failure if they have stable ischemic heart disease and does add that to prognostic information. Once somebody has known stable ischemic heart disease, however, assessment with a CT for calcium really has no role because you know they have the disease and it isn't going to change your therapy at all at that time point.